Right, so I'm going to talk about head and neck ultrasound. As Davina said, I have a bit of an interest in scanning necks. I've got a few images to go through. I'll take any questions at the end, if that's okay. So what are the advantages of neck ultrasound as compared to the other modalities that we image with? So obviously there's no radiation as opposed to a CT scan. So particularly in young patients, that's really good to avoid the radiation. There's very good patient tolerance. So a lot of patients find MRI quite difficult, can be quite claustrophobic, but you know, nearly everyone can tolerate a neck ultrasound. We get to interact with the patients, which is really important. Often we get quite limited information, and the patient can point to the lump, if there is one, tell us the history. You know, is it bigger since they referred? Is it smaller, and how it's behaving? Is there more lumps that have popped up since they were referred? So that is really helpful from our point of view. And of course, as part of a one-stop service, we can then, if we think it's necessary, go on to perform a biopsy. So a core or an FNA, depending on the lesion that we're seeing, which you can't do with CT and MRI really. Disadvantages are, obviously it's quite operator dependent, quite different to scanning, ultrasound scanning the rest of the body. And there is a bit of a learning curve. So it does take a little while to get to grips with it. And obviously clinicians can find interpretation of ultrasound images quite difficult. You know, I think ENT surgeons are quite used to looking at CT and MRI scans now, but perhaps find it more difficult to look at ultrasound images. And we only have static images of ultrasound rather than usually the whole neck. And we see deep structures less well. So things like a deep lobe of parotid, we see less well than perhaps some of the more superficial structures. So what can we see? Obviously, the main things that we're looking at in the neck are the thyroid, salivary glands, neck nodes, vessels, and we can also look for sort of the indeterminate neck mass. And I'll run through some examples of pathology in each of those areas as I go through now. So this is a picture of a nice, normal-looking thyroid gland. So this is the trachea here with the isthmus overlying it. Right lobe, left lobe, and then the common carotid arteries with these black holes on either side. So this is a normal looking thyroid, but nearly everyone, it seems, has at least one thyroid nodule, more common as you get older and more common in women. So we see lots and lots of thyroid nodules, and the difficulty is knowing which ones are significant and which ones aren't. And to help with that, we have the U grading. So very similar to something the breast radiologists use to classify breast lesions. We have a grading system looking at thyroid nodules and trying to work out which ones are benign, which ones are indeterminate, and which ones are malignant. And so a U2 lesion is a benign lesion, and typically these are often cystic or spongiform in characteristic. Sometimes have some peripheral calcification and often have peripheral vascularity. So if they have those features, we can be relatively reassured that they're benign. More indeterminate lesions tend to be a bit more solid, often have some central vascularity, and suspicious lesions, U4 or malignant lesions, U5, are often very hypoechoic, can have some sort of speckled microcalcification in the case of papillary cancer, more lobulated, and obviously we look for nodes as well. So these are both U2 lesions. The image on the left is predominantly cystic. The black spaces are fluid. There was no significant blood flow on Doppler, and it's got a bit of a hypoechoic halo around the edge as well here. These are all benign features, didn't look worrying. The image on the right has some definite colloid here. This is very typical of colloid, these so echogenic foci here, and it can often form in clumps. And the area on the right is also an area of colloid, which looks quite solid, but there's no flow on Doppler, so we can be quite reassured that that is a colloid cyst and is a benign lesion. This is a more indeterminate lesion, a U3 lesion. It is solid, it's a bit more hypoechoic than the background thyroid, and there was some internal vascularity on this on Doppler. So we would want to go on and FNA this to try and work out whether it's a suspicious lesion. I mean, follicular lesions often have this sort of appearance. And these are more suspicious lesions. The image on the left, hopefully you can see medially there, it's got quite an irregular outline, quite an infiltrative looking margin. And this actually turned out to be a medullary cancer. And the lesion on the right is actually turned out to be an anaplastic carcinoma. Obviously the history is normally a giveaway there, often very rapidly growing, very firm. And there was some vascular encasement as well with this one. And obviously in all these cases, we want to look very closely at the neck nodes as well. And anything that is U3 or above, we would go on FNA there and then. This is an example of a metastatic papillary carcinoma. So the lesion on the left is within the thyroid. It's got some microcalcification. It's generally hypoechoic background compared to the background thyroid, and is a little bit ill-defined. So that is a suspicious looking thyroid lesion. I'd give that, probably go straight to U5 with that sort of lesion because of the microcalcification. I'd have a high index of suspicion that that is a papillary cancer. And this is the same patient who actually, and this is the reason they presented with a neck node, and this is a neck node slightly higher up the neck, and this was a cystic node, and metastatic papillary cancer can sometimes have quite large nodes, sometimes can be cystic, and occasionally they present with a node rather than the thyroid lump. So we see sort of nodes like this, we should always have a very close look at the thyroid to see whether that is the primary, and if necessary go on an FNA both of them. So multinodular goitres, I mean, we see a lot of these, obviously more common in older patients. What we will try and do is look at each of the nodules, make sure that they are all sort of similar in appearance, nothing that looks particularly suspicious, because you can sometimes have a cancer within a multinodular goitre, but with a multinodular goitre, you can't go FNAing every nodule, and it's relatively reassuring if all the nodules look very similar. There's nothing that stands out as being particularly different. You can be relatively reassured, particularly if the history is sort of slow growing. Things that we can look at when assessing a multinodular goitre is the position of the trachea. So the trachea is here. So I will always sort of have a look and see, is the trachea displaced? Obviously, it can be significantly deviated to the left or the right, depending on where the largest nodule is. Or you can sometimes even see tracheal stenosis, which is obviously quite useful to let the surgeons know. And also we will look for the lower pole of the thyroid. Can we see below it? And if you can't see below the thyroid, then you can be concerned there's retrosternal extension. And we then can't fully assess what's going on behind the sternum, and we'll probably advise a CT scan. But if you can see below it, we can be reasonably reassured there's no retrosternal extension. This is quite an interesting case. This is quite a young woman in her 30s who presented with quite a hard, tender thyroid mass, and had a very sort of bizarre appearance on ultrasound. Never seen anything quite like it before. Very heterogeneous in appearance. And I was quite concerned this was some sort of thyroid malignancy, could it be something like a lymphoma? And very hard when we biopsied it. It's quite hard to get the needle in, but and eventually we did an FNA and a core biopsy on this lesion, and it turned out to be Reidel's thyroiditis, which is quite unusual, but you'd never want to just ignore that, I think, and assume it was a thyroiditis. You'd always want to go on and biopsy that, because I think there is always the risk that that could be a malignancy. So moving on to salivary glands now. This is a typical example of a submandibular gland. This is the right submandibular gland, quite wedge-shaped, sort of thinner medially than it is laterally. And then on the right side, that's a parotid gland. So this is an image taken in the preauricular region. Ultrasound is very, very good at assessing the salivary glands, looking for lesions, looking for stones, looking for dilated ducts or sialadenitis. And so we're looking for all those things when we're scanning the thyroid gland, the salivary glands. These are a couple of examples of pleomorphic adenoma. The lesion on the left here is quite a superficial lesion, not particularly large, but you can see it's sort of bulging out the cortex of the parotid gland here. Pleomorphic adenoma are usually quite hypoechoic, and there's often some posterior acoustic enhancement, which you can get with cysts as well. And look at this lesion, on first impression, because it's so hypoechoic, you'd wonder whether it's cystic, but there is some subtle internal architecture, and there was some flow on Doppler as well. So you knew it was a solid lesion. And this is another pleomorphic adenoma, which has got quite a lobulated margin, slightly larger. And the next screen shows some examples of Warthins tumours. The giveaway with the image on the left, that this is a Warthins tumour, is that the lesion is multifocal. The larger lesion here, which has got the calipers on, but then there's a similar lesion more superficially, and then another lesion here as well. So there's actually 3 lesions in one gland. So if a lesion is multifocal within a salivary gland, you're more likely to be a Warthins tumour. They also tend to be more common in smokers. And the image on the right is another Warthins tumour, which has got a cystic component here. I'm not quite sure how well it's projecting, but so in my experience, Warthins tumours are more likely to be partly cystic than pleomorphic adenoma, but there is a crossover in appearance, and you can't be 100% sure which of those you're dealing with, or even completely rule out a salivary gland malignancy, even though it looks well defined. You would always want to go on and FNA these just to make absolutely sure you're not dealing with a salivary gland malignancy. And this is an example of a Parotid cyst. And again, it's quite difficult to know for sure. This one's got some internal septations. And an abscess could look similar as well, or potentially another, even a salivary gland malignancy could look not dissimilar. So a lot depends on the history. If they had inflammation, you might think it's an abscess. Looks predominantly cystic, so you think it's probably a cyst, but again, I'd probably want to go on an FNA this and aspirate this, and we just got cyst fluid out of there, and it resolved over time. So ultrasound is also very good at looking for salivary gland stones. This is a calculus in the submandibular gland. It's a 4 millimeter calculus, and you can see there's some duct dilatation here. Sometimes it can be difficult to know what's dilated ducts and what are prominent vessels, but Doppler is very good at sorting that out. And there is a further larger calculus at the gland hilum, measuring 9 millimeters. So we're very good at looking for stones. Very tiny stones we don't always see, particularly if they're more distal within the duct, but we can follow the route of the ducts of both the parotid and the submandibular glands and try and trace them and work out if there is a sort of focal obstructing stone there. So this is a sort of, always find these quite fascinating. These are focal sialadenitis or Kuttner's tumours, and they're very obvious on ultrasound. They're very hypoechoic and look quite mass-like, but then you if you look at them closely, they don't actually alter really the shape of the gland. The normal margin is preserved on this submandibular gland here, and you can see vessels are actually running through it on the right hand image. So there's no distortion of the architecture of the vessels, which a mass lesion would normally do. So this is quite a typical appearance. I mean, you're relatively certain that is what it is. And it's interesting, it's very obvious to see on ultrasound, but when you MRI it, it's often much more subtle. Sometimes we go on an FNA that is, sometimes we follow them up with ultrasound just to make sure they're resolving, which they often do over a period of time, but can take quite a long time to resolve. So this is an example of Sjogrens syndrome involving both the parotid and submandibular glands. This is the submandibular gland, so the body marker here, and this is the parotid gland. And this tends to have quite a heterogeneous appearance, lots of sort of microcystic areas, and you can be fairly certain that it's something like Sjogrens. Can sometimes look almost like microabscesses as well. Occasionally you see this incidentally when you're scanning a neck for another reason. You can sometimes see quite normal looking salivary glands. I've had that on a few occasions. And if you say to the patient, do you suffer from a dry mouth? I've had on a few occasions patients say, oh yes, how do you know? I've never known what that's due to. And then at that point you can suggest they might get referred, but sometimes they present with quite enlarged and tender salivary glands. So one of the advantages of ultrasound is that obviously we can see the patient and talk to them. This patient was referred up with a mass in the left parotid gland, and you can see on the ultrasound image there's quite a large hypoechoic mass extending into the deep lobe of the parotid, slightly ill-defined, quite worrying looking. But I noticed the patient had a scar on the forehead and they'd had a previous SCC removed. So given that information, then it's, makes it much more likely this is going to be a sort of metastatic deposit. And the MRI image here shows the lesion within the left parotid gland with central sort of necrotic looking lesion and some peripheral enhancement. This is an example of a malignant change within a pleomorphic adenoma. This patient had a long-standing, quite large mass within the parotid gland, but they'd lived with it and quite happy with it. And then all of a sudden it started to rapidly grow. Fairly typical history of carcinoma, pleomorphic adenoma, and this was confirmed on biopsy. So the history is obviously very helpful here, knowing that it was a pre-existing mass that had rapidly grown, but I don't think you know that for sure by looking at it, but you could definitely be concerned it was an aggressive lesion, given the history. So we get asked to scan a lot of nodes, the majority of which are completely normal. I mean, often these are young patients with quite slim necks and suddenly feel a lymph node, and the GP feels the neck and can feel a lymph node. And I think we have to remember that actually it's quite normal to feel lymph nodes in the neck, particularly in the posterior triangle, particularly in young people with slim necks. I mean, we get asked to scan these tiny nodes all the time. This is only 2 millimeters in short axis. Often they sit on top of the sternocleidomastoid, and you know, the patients turn the neck and tense the muscle and can feel this tiny node, and you know, often they get referred up on 2-week wakes. So it's not necessarily a good use of resources. You know, that sometimes they're struggling to find them when they're referred as well, which can be a bit frustrating from our point of view, with these tiny nodes that are barely palpable. And it's, you know, every list I have something like this. This is a slightly larger node. This is in the level 2 jugular digastric region. This is you know, it's quite big. You know, it's 13 millimeters, but it has a relatively normal morphology. It has an oval shape. It has a fatty hilum, and it had normal flow on Doppler. And the patient had a recent viral illness, so I could relatively reassure that this is just a reactive node. And I think if we're uncertain, we do sometimes bring them up for a follow-up scan, but I wouldn't really want to go and biopsy this, particularly in a young patient with a history of a viral illness. As I said, we will bring them back for follow-up if we have any doubts. And these are more suspicious lymph nodes. The image on the left has, although it has a fatty hilum, it's slightly coarsened echocardiogram texture, and it's got a thickened cortex as well. And the node on the right is also, it's more rounded than normal, it's more heterogeneous appearance, lost the fatty hilum. So these are suspicious lymph nodes. And these are both lymphomatous nodes. And these tend to light up on PET. These are both metastatic SCC nodes. Again, this node is rounder than you would normally see. It's enlarged, it's lost the fatty hilum, and it's very heterogeneous in appearance. And the node on the right has quite a large cystic area here. And we commonly see that, particularly in head and neck cancer. And sometimes these nodes can be very, very large with quite a very small occult primary, and they present with the neck node. But if you ever see a node with cystic change within it, you've got to be concerned that is a metastatic SCC. And would always go on and biopsy these if we saw them. Obviously, infection can cause lymphadenopathy. This is a patient with quite a large node, very lobular, quite heterogeneous appearance with some sort of cystic change within it. And this turned out to be TB. So I think we always need to think about things like TB, particularly when they look like this. And if we have sort of strong clinical concerns, we biopsy that, we need to send a sample off for microbiology as well. It's sort of helpful to think about that. So other neck masses we can see, I mean, see all sorts of things, lipomas, branchial cleft cyst, paraglossal duct cysts, nerve tumors, carotid bod tumors, and I've got a few examples of some of those as well. Lipomas is quite a common presentation to get a scan. And if the lipoma is particularly large or rapidly changing, we obviously need to scan them, but sometimes you get patients referred up who have had a 20-year-old history of a lump that hasn't really changed, and they go to the GP for another reason, and sometimes they're referred for a scan. And again, you do sometimes wonder whether that is a necessarily good use of resources. But they often have quite a sort of striated appearance, the lipomas. Sometimes they're easier to feel than they are to see on ultrasound because these can blend into the adjacent fatty tissue. And this is an example of a branchial cleft cyst. It's a typical location. You can see this on the MRI here, is sandwiched between the submandibular gland and the sternocleidomastoid. And you can, if it's in a young patient with a cystic lesion in that location, you can be reasonably reassured that's what it is. But you've got to bear in mind that anyone over 40, you should never just dismiss something as a branchial cleft cyst, because occasionally a cystic node can present in this location and be mistaken for a branchial cleft cyst. And we've seen several examples of where something's been labelled as this and turned out to be a metastatic SCC. So you would always want to go and biopsy this, particularly in an older patient, just to make sure. This is an example of a thyroglossal duct cyst. It's in the right location, the midline of the anterior neck. Rather than being purely cystic, it has got quite a lot of debris within it, so it almost looks pseudo-solid. But you can assess that with colour Doppler and work out it is cystic. Obviously moves when sticking the tongue out and is often closely sort of embedded within the strap muscles, can become infected and can sometimes occasionally get malignant change within, but that's obviously very rare. And this was quite an interesting case. This was quite a young woman in her 30s who had recently been diagnosed with breast cancer. When they examined her, they found a supraclavicular mass, which she was unaware of. And obviously there's huge anxiety that this was going to be metastatic breast cancer. And she had this quite weird looking mass, quite large, with some cystic change within it, but didn't look quite right for a lymph node. I did wonder at the time whether it was a nerve sheath tumour. It's always worth being a little bit careful when you go on to biopsy these, because obviously nerve sheath tumours can be quite painful when you stick a needle in. But she did tolerate it very well, and it did turn out to be a nerve sheath tumour. So it was nothing to do with her breast cancer. We not infrequently get asked to scan cases of dental infection, and sometimes the clinicians and the patient are unaware it's dental infection when they're referred. I mean, this patient was quite an elderly lady. She had this hypoechoic area next to her mandible in the submandibular region. Wasn't really painful, had no dental history. Looked quite inflammatory though, looking at it. Wasn't quite sure what it was though, but I did wonder with its proximity to the mandible whether it could be dental infection. So I sent her around for an OPG, and you can see on the OPG there's this periapical lucency here. So rather than biopsying it, I thought, well, we'll wait and get a CT as well. And the CT shows she's got this defect in the lingual margin of her mandible. And yes, it was all due to dental sepsis. And sometimes the masses we see on ultrasound are just the tip of the iceberg. I mean, this is quite a large, aggressive looking mass in the supraclavicular fossa of a relatively young woman. And she was having symptoms in her brachial plexus as well, so nerve root pain down her arm. And on ultrasound, we can only see what's in the supraclavicular region. We can't see down to chest, obviously. And when she was CT'd, the mass that was actually going all the way down into her anterior mediastinum, and this is quite an aggressive tumour, unfortunately. And I think it turned out to be adenocarcinoma. I don't think we could tell that, but we could biopsy it from the neck, which is obviously much easier than trying to biopsy the mediastinal component. So, in summary, ultrasound is the best first-line investigation for palpable neck lumps. It's much better if you have the radiologists who can scan necks available to do that in the first instance, rather than jumping to CT or MRI. And for some things such as thyroid lesions and salivary gland lesions, often you get more information than you would necessarily with CT and MRI, although sometimes you need more than one investigation more than one modality to investigate. And it enables biopsy of lesions, and I'm a great believer if you see something, you should ideally go on and biopsy them there and then, rather than bring them back, as long as the patient is up for that, because that just adds further delay. All right, so I'll stop there. It's a very quick run through.